So first of all, thanks to everybody for the Red Sox tickets. So those tickets were for this past Monday evening, and my wife and I had a great time. I don't know if you knew this, but the seats were in the 5th row, right behind the, right behind.
So that's taken from your seat?
That's taken from my seat. So that's as close as I'll ever get to Big Poppy. And I'm glad that he was spinning in the other direction. He was coming in my direction. And how much better does it get than this? So I don't remember which inning this was, the 4th or the 5th inning, so Big Poppy is up to bat. And notice the guy with the Manny Machado shirt, the Baltimore Orioles fan. He's taking pictures, but it's not a Big Poppy, obviously. And in a minute, watch what happens. If any of you watch the game, you know what happens. So, now everybody gets up except the guy with the who sits down. So that was pretty cool to be able to take a video of Big Poppy hitting a home run. So this had been
one of his last.
One of his last. This had been the 3rd game this year that my wife and I had gone to, and I have had a lot of videos of Poppy at bat where I'm sitting much further away that I then deleted off of my phone because nothing happened. So this was, this was pretty cool, and see them running by. So it was a fun time. I think the Red Sox ended up winning 12-2 or something like that. So those of you who know me know that I'm an evidence-based guy, and I like to apply evidence-based medicine to patient care. However, you may have also heard me use the line that we need a sound understanding of the underlying physiology to apply the evidence wisely. So we need to know the evidence, but we need to know about the underlying physiology for patients so that we know when and how to apply the best evidence. So as Bob said, we're going to go through a series of discussions about respiratory physiology, and this more or less follows John West's Respiratory Physiology book, if any of you might have used that book in school. So it begins with a discussion of ventilation, which we'll talk about today, and then next time we'll talk about diffusion, then blood flow, then gas exchange, blood gas transport, acid-base balance, mechanics, and control of breathing. So there are 8 topics here, and if we do roughly 1 a month, this will keep us busy for the next 8 months, and probably at that time we could go back and start again at the beginning.
We'll get another list for you at that time.
So here's a cast of the human respiratory tract. This is right out of John West's textbook. And the point here is that the first 16 branches of the respiratory tract are the conducting zone. That's anatomic dead space. That's gas that needs to move in and out of the lungs just to get gas to the respiratory zone. And from the 17th to the 23rd branching of the respiratory tract, there are actually alveoli, and that's where the action occurs. That's where gas exchange occurs. That's the alveolar ventilation. And most of the respiratory tract consists of the respiratory zone, as is illustrated here. So the total cross-sectional area of the respiratory zone, the alveoli within the lungs, is much greater than the conducting zone, the airways moving gas between the proximal airway and the alveoli. So today we're going to talk about the relationship between PCO2, alveolar ventilation, and carbon dioxide production. So I will show you some equations. So again, those of you who know me know that I like equations. So we're going to be seeing equations as we go through today's lecture and the following one. We will compare alveolar dead space, anatomic dead space, and mechanical dead space, explain the effect of dead space and carbon dioxide production on minute ventilation requirement, and then we'll discuss the role of capnography to assess ventilation. So here represents the normal condition as you and I are breathing now. So normally our tidal volume is about 400 milliliters. it's about 6 mLs per kilogram. So when we talk about ventilating patients in the ARDSNet study, we often talk about high tidal volume versus low tidal volume. One of the things that I like to point out is 6 mLs per kilogram is essentially normal tidal volume. 400 milliliters is about what you and I are breathing now. So if we breathe at 16 breaths per minute, that's a minute ventilation of about 6.5 liters per minute. Our anatomic dead space is about 150 milliliters, about 1 milliliter per pound of body weight. So then if we subtract 150 off of 400, that gives us an alveolar volume of 250 milliliters times the breathing rate of 16 breaths per minute, which is an alveolar ventilation of about 4,000 milliliters per minute. The volume of the alveolar gas is about 3,000 milliliters. Note that the volume of blood in the lungs at any one time is only about 70 milliliters, but the blood flow, cardiac output, is 5 liters per minute, so that gives us our normal ventilation perfusion relationship of 0.8. And some of these principles we'll actually come back to over and over as we go through these series of lectures. But perhaps the most important point that I wanted to make from this slide is that a normal tidal volume is about 6 mLs per kilogram, about the tidal volume that many of us now would recommend as a reasonable starting point when placing patients on mechanical ventilation. So all of the exhaled CO2 comes from alveolar gas, and all metabolic CO2 is cleared from the lungs unless you're on ECMO. So if you're on ECMO, then there is CO2 that is cleared extracorporeally, but otherwise all of the CO2 that we exhale comes from the metabolic CO2 that is produced by our tissues. So here's the equation that is the most important one from today's lecture that we'll come back to several times throughout the presentation, which is that the arterial PCO2 is determined by CO2 production in the numerator divided by alveolar ventilation in the denominator, and then the 0.863 is just for conversion of terms. So notice that CO2 production is typically in standard conditions, alveolar ventilation is typically in body temperature and pressure saturated, and one of them is milliliters per minute, one of them is liters per minute, so the 0.863 makes all of the corrections for different units and so forth. So note that in the denominator of the relationship is alveolar ventilation, not minute ventilation. So typically we, on mechanically ventilated patients, think about the minute ventilation as determining the arterial PCO2, but it's really the alveolar ventilation, as we will explore further over the next minutes. Normal carbon dioxide production is about 200 milliliters per minute. Normal alveolar ventilation is around 4 liters per minute, or in this example, I use 4.25 liters per minute. And if you do the math, if you plug the numbers into the equation, you end up with a normal PCO2 of 40 milliliters of mercury. So the numerator of the equation is CO2 production. So let's elaborate a bit more on CO2 production. So a normal carbon dioxide production is about 200 milliliters per minute, or that's about 2.8 milliliters per kilogram per minute. And there are things that will increase or decrease the carbon dioxide production. So for example, carbon dioxide production is increased with sepsis and fever and exercise, and that's more than just exercise as we think about walking and running, but think about the patient who is in bed, who's moving around and pulling at things and so forth. That increases CO2 production. And increased work of breathing increases CO2 production by the respiratory muscles, and excessive calories, particularly carbohydrate calories, will drive up the carbon dioxide production. So if there's an increased carbon dioxide production, that means that you need a higher minute ventilation, that's why we breathe more when we walk and run, and or an increased CO2 production will result in a higher PCO2. So if the minute ventilation is fixed because our patient is being ventilated, then if the CO2 production goes up, the arterial PCO2 will go up. On the other hand, there are things that can decrease carbon dioxide production. So sedation and paralysis will decrease carbon dioxide production, as will a decreased body mass. So obviously a neonate's going to make less CO2 than a child, than a dog. I can recall up in the MICU a few months back, maybe 6 months back, and you might remember this patient, Kevin. There was a morbidly obese patient who had a CO2 production of 500 milliliters per minute, who had a high PCO2 and a high minute ventilation requirement. So paralysis then can reduce CO2 production. So it does that by decreasing several things. It decreases overall metabolic rate, but it decreases the work of breathing. So paralysis can reduce CO2 production, PCO2, and ventilation. So then, how do we determine carbon dioxide production? So here's another equation. So you know I like equations. So carbon dioxide production is determined by the minute ventilation times the mixed exhaled PCO2, how much carbon dioxide comes out of the lungs, divided by the barometric pressure. So mixed exhaled PCO2 divided by barometric pressure is essentially the percent of carbon dioxide in our exhaled breath. Carbon dioxide production is an end product of metabolism or energy expenditure. So if we know the carbon dioxide production, as you all know, we can calculate the resting energy expenditure, which we do with the NICO. So the CO2 production in liters of carbon dioxide per minute times 5.52, which is the kilocalories that are burned for each liter of carbon dioxide produced, times 1,440 minutes in a day, will give us the energy expenditure of our patient in kilocalories per day. So the carbon dioxide that we exhale, the carbon dioxide production then, is the end result of metabolism. If we know the carbon dioxide production, we can calculate the metabolic rate. So then how do we get mixed exhaled PCO2? Well, one thing we could do is we could take a big bag and we could hook it onto the exhalation port of the ventilator, and we could collect a big bag full of gas and measure the PCO2 of that gas, either by sending a gas sample to the blood gas lab or using a capnometer. And Kevin will remember from 20 years ago up in the Bigelow 9 MICU, I used to come up with big weather balloons that we would hook onto the expiratory port of the ventilator, and we collect these big bags full of gas, and we draw a syringe of the gas and send it to the blood gas lab. And as you can imagine, that would confuse the heck out of the blood gas lab when we got a syringe which looked like it had nothing in it. And you might recall how they would call up and ask what this syringe is that's empty. The problem with that approach is that modern ventilators that we use today have a bias flow through the ventilator circuit. And that bias flow is 2, 3, 4 liters per minute, depending upon where we set the flow trigger on the ventilator. And that bias flow is CO2 free. So if we hook a bag onto the expiratory port of the ventilator and collect a big bag full of gas, it will be contaminated by that bias gas flow. So that's not a technique that we can use anymore to get the mixed exhaled PCO2 and to determine carbon dioxide production and dead space, as we'll talk about in a minute. So how do we do this? Well, we use the NICO, as all of you know, or now it's the NM3, and this device measures carbon dioxide right at the patient's endotracheal tube, or between the Y connector on the ventilator and the endotracheal tube. So because of the position at which the CO2 is measured, it is uninfluenced. It is not influenced by the bias gas flow through the ventilator circuit. So what the NICO or the NM3 does is it looks at the percentage of carbon dioxide in the exhaled breath. And what you can see here is a normal appearing volumetric capnogram, which is what we see when we look at the screen on the NICO or the NM3. And if we have percent CO2 on the y-axis and exhaled tidal volume on the x-axis, then the area under that curve, the shaded part of the curve, is carbon dioxide production. So what the NECO then does in the software is it determines that area, reports out the carbon dioxide production. So here is our equation again. So again, this is the most important relationship that we are going to talk about this morning. So PCO2 is determined by carbon dioxide production in the numerator, divided by alveolar ventilation in the denominator, times a correction factor. So we talked about CO2 production and some of the things that might increase or decrease the CO2 production. And now let's talk about the denominator of the relationship, which is alveolar ventilation. And again, it's not minute ventilation, but it is alveolar ventilation. So as you know, the minute ventilation is determined by the dead space ventilation and the alveolar ventilation. So if dead space increases, the alveolar ventilation will decrease, and the PCO2 will increase if the minute ventilation stays constant. So we have a mechanically ventilated patient who is paralyzed, and the dead space goes up, the PCO2 will go up. Or if the patient's not paralyzed and the dead space goes up, the patient may begin triggering the ventilator at a more rapid rate. On the other hand, if the dead space increases and minute ventilation, then the minute ventilation must increase for alveolar ventilation and PCO2 to remain constant. So as I just said, if our patient is not paralyzed and the dead space goes up, then the patient may try to increase their minute ventilation to maintain arterial PCO2. So this, I think, nicely illustrates the relationship between minute ventilation on the y-axis, PCO2 on the x-axis, and then the blue lines represent different dead space fractions. So normally, our dead space is about a third of our tidal volume. So a normal VD to VT ratio is about a third, or 0.33. So for us, it would fall right along this line. So for a normal PCO2 of 40 and a normal dead space of 0.33, third of your tidal volume, we end up breathing at about 6 liters per minute. But now imagine that you get sick, like you throw a pulmonary embolism, which increases the dead space. So now if the dead space goes up to 75% of your tidal volume, in order to maintain your PCO2 at 40, you're going to have to breathe at about 18 liters per minute. And most of us aren't going to be able to breathe at 18 liters per minute for very long. So then the result is that we end up with a higher PCO2 to lower the minute ventilation requirement. So at a dead space of 75% and a minute ventilation of 10 liters per minute, we would end up with a PCO2 in the low 70s. So physiologic dead space, or dead space, is ventilation without blood flow, ventilation without perfusion, and physiologic dead space has 3 components. First of all, there is alveolar dead space, which normally should be close to 0 in you and me, which is areas of the lung that are ventilated but not perfused. So for example, the red circle there is to represent a pulmonary embolus. So if there's a pulmonary embolus, that will increase the alveolar dead space because that will contribute to parts of the lungs that are ventilated but not perfused. There is also anatomic dead space, which is the volume of the conducting airways. We can't really do anything about that. And a normal anatomic dead space is about 150 milliliters. So that's true for all of us. If we put in an endotracheal tube or a trach tube, that decreases the anatomic dead space by some, by a third to a half. But other than that, there's not a lot we can do about our anatomic dead space. And then the mechanical dead space, which is an extension of the anatomic dead space, is any apparatus that we place between the Y connector and the endotracheal tube or tracheostomy tube. And we want to, as you know, minimize the amount of mechanical dead space because that will be an extension of the anatomic dead space. That will drive up the physiologic dead space. And in that way, mechanical dead space will either result in an increase in CO2, PCO2, or an increase in ventilation requirement, or both. So here's a study that was published in Respiratory Care by some respiratory therapists about 10 years ago, looking at the effect of mechanical dead space or apparatus dead space on blood gases. So the open bars are PCO2 and the solid bars are pH. So if we begin at the right-hand panel, minimal apparatus dead space. So this is no connecting tubing between the endotracheal tube and the Y connector, and no heat and moisture exchanger. So you can see that the PCO2 is in the low 50s and the pH is right around 7.4. Now look at what happens when they add connecting tubing between the Y connector and the endotracheal tube. So that's the 6-inch flex tube. So notice that in these patients who could not increase their minute ventilation, there is an increase in PCO2. PCO2 goes from the low 50s up to around 60, and the pH drops. And now notice what happens when they add, in addition to that, a heat and moisture exchanger, an artificial nose. There is a further increase in PCO2 and decrease in pH. So this, I think, clearly makes the case that particularly during lung protective ventilation, ventilating at 6 mL per kilogram, we want to minimize the amount of mechanical dead space in the ventilator circuit, because that can impact the patient's arterial PCO2 and pH. So that's the reason why. And Kevin will remember when I went on a campaign about 10 years ago to get rid of all the 6-inch flex tubes up in the MICU when we were adopting lower tidal volume ventilation. And I was quite impressed at the time at how much that would drop the PCO2 in some patients. So it can be imparted how much extra tubing we place between the Y piece and the endotracheal tube. So when we talk about dead space, we typically talk about the dead space to tidal volume ratio. So the tidal volume divided by, the dead space divided by the tidal volume, or the total dead space ventilation divided by the minute ventilation. And common causes of an increase in alveolar dead space are pulmonary embolism. So that's kind of the classic example of dead space ventilation. Alveolar hyperinflation increases dead space, because if we hyperinflate alveoli, the effect is that reduces blood flow past those alveoli, and that results in a higher dead space. So COPD and asthma, particularly acute COPD and acute asthma, drive up dead space because of alveolar hyperinflation. And then, as we will see actually on the next slide, if we are too aggressive with our PEEP, that will cause alveolar hyperinflation, decreased blood flow past alveoli, and drive up the dead space. And if there's pulmonary hypoperfusion, such as with cardiac arrest, that will increase the dead space. And in fact, with cardiac arrest, the dead space fraction would be 100%, because it would be all ventilation without blood flow. So there might then be a role for evaluating dead space by capnography during cardiac arrest, as we'll get to in a few minutes. So normally our dead space fraction is about a third, so about a third of our tidal volume is dead space. The clinical implication is that there will be a higher minute ventilation and or a higher PCO2 if the dead space is increased. So here's a picture from this is from a paper published in 1975. Probably I looked around the room before most of you were born. A few of us were born. And I was actually a respiratory therapist then, and I remember when this paper came out. So this is a famous paper by Suter about describing how to determine best PEEP. And what I want you to look at here is, up here is the dead space. And notice that the best PEEP corresponds to the lowest dead space. So as the PEEP is increasing, the dead space is dropping till we get to the level of best PEEP, after which, if we further increase the PEEP, the dead space gets worse. Why does the dead space get worse here? Well, because we're overinflating alveoli, decreasing blood flow past those alveoli, which drives up the dead space. So then you might say, well, then why don't we measure dead space to do a PEEP titration? Well, also shown on this slide is that the best PEEP corresponds to the best tidal compliance, or the lowest driving pressure. So I would argue that we don't, this is, I think, an important physiologic point, but we really don't need to measure the dead space to determine best PEEP, because it's a lot easier to measure compliance, and the best compliance corresponds to the lowest dead space and the best oxygen delivery. So then how do we calculate dead space? Well, this is the equation. So VDVT is the arterial PCO2 minus the mixed exhaled CO2 divided by the arterial PCO2. So again, we can use a device like our NICO or NM3 to measure the mixed exhale PCO2, exactly the same as we would for CO2 production. And in fact, on the screen of the device, it reports out the mixed exhale PCO2. So if you're so inclined, you can solve the equation and calculate the dead space. Or, as you know, you can just tell the device what is the arterial PCO2, and the software does the math for you. So when in the NM3 or the NICO, you dial in the blood gases and you press the button and it tells you the dead space is 65%. On the screen, it's solving this equation, so you don't have to do it. Kevin knows that one of my favorite tricks up in the MICU had been to make people take the mixed exhale PCO2 and do the math themselves. Never made Kevin do that, of course. So shown here is the PCO2, or the CO2 coming out of the lungs during exhalation. This is actually a time-based capnogram. And the shape of the relationship between CO2 and volume or time is this. It's kind of a rectangular shape. Ideally, it would be a rectangle. So the first gas that you exhale, which is phase 1 on the capnogram, has a PCO2 of 0. So that is your anatomic dead space. So the first exhale breath is the end of the previous inhalation. That gas has not participated in gas exchange, because there are no alveoli in dead space. So the first gas that comes out of the lungs has a PCO2 of 0, phase 1. And I'll show you in a minute, actually on the next slide, how you can use this to determine the anatomic dead space. Then as alveolar gas begins to exhale, to exit the airway, there is an increase in PCO2. So that is phase 2 on the capnogram. The reason why it does not increase abruptly is because gas is coming from many different alveoli that have different PCO2s. So if we only had one airway and one alveolus, there would be an abrupt increase in phase 2 on the capnogram. Then throughout most of exhalation, phase 3, gas is coming from the alveolar space. This is sometimes called the alveolar plateau, because normally phase 3 is pretty close to a plateau, and that represents alveolar gas. And then with the beginning of inhalation, the PCO2 drops back down to 0. The PCO2 measured there at the very end of the alveolar plateau is the end tidal PCO2, reported from a capnograph or a capnometer. So then, because phase 3 represents alveolar gas, the end tidal PCO2 represents the alveolar PCO2, not the arterial PCO2, as we'll come back to in a minute. So there is a technique called Fowler's method that can be used to measure the anatomic dead space from the capnogram. So if we draw a vertical here so that the area of A is equal to the area of B, this volume represents the anatomic dead space. And one of the things that the NICO will report out is the anatomic dead space, Why does it do it? Well, it's with the software in the device. It's relatively easy to do. Is it clinically important? Probably not. What we are really interested in is the physiologic dead space more than the anatomic dead space. But from the capnogram, it is possible using this method to determine the anatomic dead space. So then, as I just pointed out, when we think about end-tidal PCO2, it is very important to remember that the end-tidal PCO2 is not the arterial PCO2. So imagine, for example, that there are two alveoli. One alveolus which is being ventilated, both alveoli which are being ventilated, one alveolus which is being perfused, the other which is not because we have a clot in the vessel. So in this lung unit, the alveolar PCO2 will be the same as the end-part PCO2, will be 0, because there's no gas exchange across this lung unit. Whereas here, in this lung unit, which we're going to assume has normal ventilation, normal blood flow, here the alveolar PCO2 will roughly approximate the arterial PCO2. But the gas which is coming out of the lungs is, in this example, half this, half this. So for this example, the end-tidal PCO2 would be half of the arterial PCO2. So dead space then, what we're talking about today, can grossly affect the relationship between the arterial and the end-tidal PCO2. So for you or me, assuming we all have normal lungs with a normal ventilation perfusion relationship within the lungs, the end-tidal PCO2 roughly approximates the arterial PCO2. So if all of our mechanically ventilated patients had normal lungs, we could measure the end-tidal PCO2 continuously on everybody, and we wouldn't have to give very many blood gases. But the problem is that many of our patients have abnormal lung function. That's why they're on the ventilator, because they have diseased lungs. So if there's an increased ventilation perfusion relationship, so that would be an increase in dead space, increased ventilation relative to blood flow, now the end-tidal PCO2 will approximate the end-part PCO2. The end-tidal will approximate the end-part PCO2, not the arterial PCO2, and the end-part PCO2 is 0. So with 100% dead space, with no blood flow, cardiac arrest, the exhale PCO2 would be 0. On the other hand, if there's decreased VQ, decreased ventilation relative to blood flow, now the end-tidal PCO2 will more closely reflect the mixed exhale PCO2. So the end-tidal PCO2, depending upon what's going on in your lungs, the end-tidal PCO2 could be as low as 0 or as high as a few millimeters of mercury greater than the arterial PCO2. So then we have to be very careful, I think, if we try to use the end-tidal PCO2 as a proxy for arterial PCO2, because depending upon lung function, there can be a large difference between the two. And if the end-tidal PCO2 changes, we don't know if it's because the ventilation changed, because the blood flow changed. We don't know if it's because of something with the ventilator, something with physiology. So I think that it can be very difficult to use the end-tidal PCO2 as a proxy for the arterial PCO2. And this is from a paper published in Respiratory here a couple of years ago, showing that the shape of the capnogram, so here's our phase 1, phase 2, phase 3, the shape of the capnogram will be affected by changes in VQ. So if there's a decrease in ventilation perfusion, then that will shift the capnogram upward. If there's more dead space, increase in VQ, that will shift the capnogram downward. So you can imagine in your patient who's being mechanically ventilated, where their lung function is changing moment by moment, hour to hour, day to day, the exhaled CO2 could be going up and down for reasons unrelated to the arterial PCO2 or how we set the ventilator. So this was illustrated nicely, I think, a few years ago in another paper we published in Respiratory Care, looking at the relationship between the arterial PCO2 and the end-tidal PCO2, depending upon what is the dead space fraction. So when the dead space was relatively normal, the difference between the arterial and the end-tidal, on average, was 0. And it's clustered very closely, the relationship is clustered very closely around 0. So if all of our patients had normal lungs, then it would be reasonable, perhaps, to use the end-tidal PCO2 as a reflection of the arterial PCO2. But notice here, when the dead space is between 56 and 70%, or notice here where the dead space is greater than 70%, there's a big difference between the arterial and the end-tidal PCO2. And in fact here, this might represent many of our patients with COPD or ARDS. The difference between the arterial and the end-tidal CO2 on average is about 18 millimeters of mercury, with a large spread in that relationship. So I think this makes it very difficult, again, to use end-tidal PCO2 as a reflection of arterial PCO2 in our patients with lung disease. So this is kind of a complicated slide that we published a couple of years ago, looking at all of the different factors that can affect exhaled PCO2. But perhaps the most important part of this slide is this graphic up here, looking at the volumetric capnogram. So CO2 is a function of exhaled volume. Here is the arterial PCO2, this dot. Here is the end-tidal PCO2, here is the mixed exhaled CO2, here is the alveolar CO2. And the relationship between those PCO2s is determined by the distribution of ventilation perfusion relationships within the lungs. And often, particularly with disease, there can be big differences between these PCO2s, such that if we try to use one of these other PCO2s to tell us about arterial PCO2, we may be wrong a lot of times. So then what about the use of capnography during CPR? So this is something that's received a lot of attention just over the last 5 years or so. And the idea here is that the end-tidal PCO2 will be 0 because there's 100% dead space with no pulmonary blood flow with cardiac arrest. The end-tidal PCO2, oh, I see that's redundant, but at any rate, the end-tidal PCO2 can then be used to assess CPR effectiveness. So if we do more effective CPR, that should increase blood flow through the lungs, and that should increase the exhaled CO2. It's been shown now in several studies that there is poor prognosis if the end-tidal PCO2 is less than 10 for after 20 minutes of CPR. The reason for that is if the end-tidal PCO2 is less than 10, that means there's very little pulmonary blood flow. If there's very little pulmonary blood flow, there's very little cerebral blood flow, coronary blood flow to other parts of the body, which probably reflects hypoxia. An abrupt increase in end-tidal PCO2 indicates a return of spontaneous circulation. So here I think are some good examples of that. So on the top, CPR is ongoing. Here the person who's doing compressions is getting tired. As they're doing compressions less effectively, the end-tidal PCO2 drops because pulmonary blood flow drops. And then they switch to a different person doing compressions, and the end-tidal PCO2 goes up because pulmonary blood flow increases and dead space goes down. On the bottom shows what happens with return of spontaneous circulation. So here they stop to shock the patient. End-tidal PCO2 goes to 0, no pulmonary blood flow. Then the patient gets shocked, and the patient has return of spontaneous circulation, and the end-tidal PCO2 increases to essentially normal because there is now blood flow through the lungs, and the dead space, the high dead space, is going away. And I think it's also important to appreciate, we always need to appreciate taking care of patients with sick lungs, is that there is a lot of heterogeneity throughout the lungs. So there are 300 million alveoli, and they may be having 300 million different VQs and time constants and so forth. So let's imagine that we have two alveoli, and this alveolus is relatively normal. So here the PCO2 in this alveolus will closely approximate the arterial PCO2. But in this alveolus, there is a partial obstruction in the airway leading to that alveolus, so that it takes a long time for this alveolus to empty. So this is a high time constant here. And because it takes so long for this alveolus to empty, the result is that the PCO2 increases in this alveolus. So we have one alveolus relatively normal, one alveolus that empties slowly that has a high PCO2 because of that slower emptying. So the result of that is that there's an increase in the slope of phase 3 on the capnogram, because the slowly emptying lung units, these lung units, have the highest PCO2, and they are going to be contributing CO2 closer to exhalation. So in patients then who have severe obstructive lung disease with a lot of heterogeneity of lung units throughout the lungs, typically the slope of phase 3 is increased. And in fact, if we treat the lung disease, we will see that the slope of phase 3 will decrease. And there are actually papers in the literature that describe patients coming to the emergency department who have severe acute asthma. They look at the capnogram. The capnogram's gone up like this. They treat the patient aggressively with bronchodilators and steroids, and the capnogram normalizes. So then you may say, well, why don't we take the NICO to the emergency department for patients with severe acute asthma to assess the response to therapy? And as I used to tell the fellows up in the MICU, well, the NICO, the NM3, costs what, 15,000, Dan? Yeah. And a peak flow meter costs $25, and you get really the same information. But I think it's an interesting point in physiology. And here's a patient. I don't know if you remember this patient. This was the lady up in the MICU maybe 15 years ago now, who had severe emphysema and had a unilateral lung transplant. So this is the transplanted lung. So she comes back into the hospital, intubated and respiratory failure, and in the transplanted lung there's probably either rejection or pneumonia. And here is the native lung. So this was a unilateral transplant. So this lung was transplanted. This is the native lung, which is very emphysematous, and you can see how hyperinflated that is. So if you think about it, this lung is going to be stiff, so these alveoli are going to exhale the gas relatively quickly. These, in this emphysematous part of the lung, there are long time constants, and it's going to take a long time for those alveoli to exhale. So, and I don't even remember exactly why we put the NICO on her, but after we did, we saw some very interesting findings. So here is the capnogram, and notice that it is biphasic. So this presumably represents this lung exhaling, and then the PCO2 drops, and then it increases. These are cardiac oscillations. It has an increasing slope. This presumably is this part of the lung exhaling. So again, there wasn't much we could do about it, but it was certainly an interesting, at least for me, it was a very cool physiologic anomaly. So the other thing that we have grown to appreciate over the last 15 years is that there's a relationship between dead space and outcomes from ARDS. So this is from the first paper to describe this, published in the New England Journal of Medicine back in 2002. Subsequently, there had been at least a half dozen, if not more, papers that have been published that have confirmed this observation. And that is that mortality increases with an increase in dead space fraction. So if your dead space is over 70% and you have ARDS, this would suggest that your mortality is very high. And if we can do things that might, so this is what we don't know, I guess, but is whether then we can do things that will reduce the dead space and improve outcomes. So presumably so, but that part has not really been studied. So if you have then a patient who has a high dead space, so how would you know if your patient has a high dead space? Well, if their minute ventilation is 15 liters per minute and their PCO2 is 70, you probably don't need to measure their dead space. Their dead space is high. And why might that be important? Because if the patient has ARDS, that has been associated with poor outcomes. So then, when you think about ventilation, so this is my kind of my summary slide. So think about your patient who has a high minute ventilation. So your patient's on a ventilator, they have a high minute ventilation. That could be because they have a high dead space, or they have a high carbon dioxide production. And if we don't know which it is, or it could be both, if we're not sure which it is, that might be a reason that we would get the LECO or the NM3, because that way we can determine relatively simply what is the dead space fraction, what is the carbon dioxide production. Or the high minute ventilation may be due to hyperventilation, and you can determine that quickly by just looking at the arterial PCO2. So if the patient's minute ventilation is 15 liters per minute and their PCO2 is 0.5, then the high minute ventilation maybe is just because the patient's hyperventilated. On the other hand, if your patient has a high PCO2, that may be because they have a high dead space or a high CO2 production, or it might be because they're hypoventilating, they have a low minute ventilation. So if the PCO2 is 60 and their minute ventilation is 2 liters per minute, then the high PCO2 may just be because we need to crank up the ventilator. And then the final equation, so this is just sort of a rearrangement of some of the previous equations that I showed you. So the arterial PCO2 then, in the numerator, and in the denominator, alveolar ventilation. And alveolar ventilation is the difference between the minute ventilation